Hi, everyone. Welcome to the Lymphoma Research Foundation's Treating Lymphoma with Bispecific Antibodies webinar. My name is Hope Avalon, and I am the Senior Manager of Patient Education Programs here at the Lymphoma Research Foundation. During today's webinar, you'll hear from two expert speakers, and you'll have an opportunity to ask questions. So you can submit those questions at any time in the Q&A box at the bottom of your screen, and we will get to as many as we can before the end of the program today. And as a reminder, this webinar is being recorded. Also, at the end of the program, you'll be prompted to complete a brief program evaluation. We do ask that you complete this evaluation as we like to incorporate your feedback into future programming. But for now, let's get started. Thank you again, everyone, for joining us on today's webinar. At the Lymphoma Research Foundation, our mission is to realize the promise of science, to eradicate lymphoma, and serve the community touched by the disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. At the Lymphoma Research Foundation, in addition to today's program, we have a variety of other programs and services available for you. So we offer both in-person and virtual programs so that you can continue learning about the latest updates throughout the year. So to view and register for any of our upcoming programs, you can visit lymphoma.org/programs. And in addition, the foundation offers a wide range of support services. So starting with our helpline, which serves to complement our patient education programs as a resource for both patients and care partners. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation through our clinical trials information service, and connections to resources such as financial assistance. Lastly, we also offer a peer support program called the Lymphoma Support Network. And through the Lymphoma Support Network, we can connect patients and care partners with others who have been through similar experiences for emotional support. The foundation also offers a wide range of digital resources. Comprehensive disease guides and fact sheets can be ordered or downloaded on our website. Again, that's lymphoma.org, where you'll also find disease and treatment-specific videos. We also have an award-winning mobile app called Focus on Lymphoma. The app provides helpful disease content as well as unique tools to help patients better manage their lymphoma. So that app is available free of charge in the Apple App Store and in Google Play. I'd also like to take a moment before we begin to thank our program supporters. Thanks to their generous support, we're able to host programs like today's webinar. But we do have a wonderful program planned for you today with two expert speakers, like I mentioned, Dr. Manali Kumdar and Dr. Jennifer Crombie. I'm so honored to introduce our first speaker, Dr. Manali Kumdar. Dr. Kumdar is a hematologist-oncologist at the University of Colorado Medicine, where she's the clinical director of lymphoma services. She's also an associate professor of medicine in the Division of Hematology. Thank you so much, Dr. Kumdar, for speaking on our program today. And with that, I will now turn the talk over to you.
Thank you so much, Hope. I'm going to quickly upload my presentation. So very good morning, good afternoon to everyone who has logged on today to really engage in this discussion around a new frontier in non-Hodgkin lymphoma treatment called the CD20 bispecific T-cell engagers, the acronym BiTE. So my job today is really to take you through an overview of these bispecific antibody therapies in lymphoma and to outline when to consider these treatments. I would obviously be talking about the FDA-approved indication for this treatment. And then Dr. Crombie will take over and discuss in depth some new treatments with regards to clinical trial activity with bispecific antibody treatments. So there's a lot that we have to pack in an hour. We'll obviously take questions in the end. So without further ado, I'm going to get started. So the age-old concept of treating a cancer, including lymphomas, was to do either chemo treatments or radiotherapy. Chemo treatments and radiotherapy, they are agnostic. They basically kill the fast-growing cells of your body. So they kill cancer cells, but they do that at the expense of normal fast-growing cells of your body. And thus, patients may experience side effects such as nausea, vomiting, diarrhea, hair loss, because normal fast-growing cells get affected. The new tool to treat lymphoma is immunotherapy. And immunotherapy unleashes the patient's own immune system and reprograms it in a way that it can now kill cancer cells and spare the healthy cells. So reprogramming can occur in a variety of ways. And one of the reprogramming tools is this new treatment, which is the bispecific T-cell engagers. It clearly made a big splash in all the leading journals with regards to immunotherapy and its application in destroying cancer. I will say that lymphomas has been at the front end of this race because some of the most exceptional responses with immunotherapy have occurred in patients with lymphoma. So to give you a quick overview of utilizing immunotherapy, I think it's really important to understand what is our immunity, how does the interplay happen, and what are the two distinct types of immunity that get triggered when our body gets exposed to a foreign antigen. It could be an infection, it could be a malignant antigen. So the two distinct types of immunity are what we call innate immunity and adaptive immunity. Innate immunity typically triggers within a few hours of the body being exposed to a foreign antigen. It particularly consists of agents or cells such as the NK cells, the dendritic cells, and the macrophages. On the other hand, the adaptive immunity kickstarts a little bit later, however, has memory to that germ or the antigen, which the innate immunity doesn't have. The adaptive immunity is an interplay of what we call the B lymphocytes and the T lymphocytes. And each of them assist in eventually killing the germ or the infection or the cancer. For example, the B lymphocytes activate the T lymphocytes. The T lymphocytes activate the plasma cells and make antibodies that can kill the germs or infection or cancer. At the same time, there is a subset of T cells called the cytotoxic T cells that eventually have a much robust response and cause complete cytotoxicity. And the adaptive immunity eventually enhances the innate immunity. So the constant interplay has been the focus of intervention with regards to what we can do to manipulate our own immunity when patients develop a malignancy. So in the world of lymphoma, when our own immunity is not able to recognize lymphoma as a foreign antigen, what can we do to manipulate each of these cells so that they can be engineered to be able to destroy lymphoma is the basis of the birth of immunotherapy. And over the last 3 decades, there has been relentless research which finally came to fruition with the development and approval of what we call CAR T cells. And then since CAR T cells got approved, there has been a splash of many other immunotherapy molecules, including bispecific T-cell engagers, which we will be talking about. So this is the landscape, and it is only growing, which I'm sure Dr. Crombie will talk about in just a little bit. But to go ahead and talk about the two most promising immunotherapy updates, we obviously have CAR T cells. CAR T cells is basically taking a patient's own blood, isolating the T cells of patients, genetically engineering them to make synthetic receptors that have the ability to bind to the lymphoma cell and activate a T cell cascade to be able to kill the lymphoma cell. Now, the manufacturing of the patient's T cells happens outside in a lab, and that means it is not off the shelf. I just cannot say I want to give a patient a CAR T cell therapy and that will not be available tomorrow. It takes usually at least 3 weeks to manufacture. The advantage of this new treatment that we are going to talk about, which is CD20 bispecific T-cell engager treatment, is that these are off-the-shelf antibodies. These are infusions or shots that are available tomorrow if I was to want to treat a patient for their lymphoma that can be given, and therefore the time that it takes to actually give treatment is substantially shortened. So, of course, this is an audience that is not foreign to the word lymphoma, but I think just to give a quick update, lymphoma is not one disease. It's actually made up of, it's a heterogeneous group of subtypes, nearly 100 subtypes, and broadly they're divided into what we call a non-Hodgkin lymphoma and Hodgkin lymphoma. Non-Hodgkin lymphoma further divided into B-cell non-Hodgkin and T-cell non-Hodgkin. B-cell non-Hodgkin lymphoma makes up for the majority of non-Hodgkin lymphomas, and nearly 100,000 patients are afflicted with non-Hodgkin lymphoma annually in the United States. So you can see, we see a lot of patients who have a diagnosis of a B-cell non-Hodgkin lymphoma. B-cell non-Hodgkin lymphoma is further divided into what we call an aggressive phenotype, aggressive B-cell non-Hodgkin lymphomas, such as diffuse large cell lymphomas, Burkitt lymphoma. We have what we call chronic or indolent lymphomas, such as follicular lymphoma or CLL, which is chronic lymphocytic leukemia, also called chronic lymphocytic lymphoma. And then there is the mixed bag, wherein we typically have our poster child here, which is mantle cell lymphoma, which usually has properties of both indolent as well as aggressive. Aggressive lymphomas are usually curable with frontline chemoimmunotherapy. However, nearly 40% of patients will relapse, and thus it is very important to develop treatments for aggressive lymphomas. For chronic lymphomas, we have these chronic entities where patients live with it for the rest of their lives. They are certainly treatable. Treatments put these patients in a remission. However, at some point, patients come out of remission, meaning they relapse. And thus, it's really important to design treatments that can hopefully provide patients a long-term remission. And of course, our zest to cure indolent lymphoma continues in the form of clinical trials. And with regards to mantle cell lymphoma, because it can either present aggressively or it can be very indolent, our strategies can be tailored to the heterogeneity of the presentation. So just to quickly go to what all have we done in immunotherapy so far. So just like an antibody can kill a germ, because it can attach to the antigen on this germ and then eventually cause cytotoxicity or lysis. Similarly, an antibody can be engineered towards an antigen that is expressed on the lymphoma cell and thus targeted to destruction. Usually, the most common antigen that we have explored has been CD20. CD20 is an antigen that is expressed on all B cells. And as you know, majority of non-Hodgkin lymphomas that we talk about are B-cell lymphomas. So B-cell non-Hodgkin lymphomas unanimously express CD20, barring a few. And thus you can tailor or make or manufacture an antibody that is targeted to that B-cell non-Hodgkin lymphoma that expresses CD20 and cause the lymphoma cell to die. So with that, you can see how we have been able to harness this immune system. The first success came through the wave of antibodies, which was CD20 antibodies, namely rituximab and then obinutuzumab. Basically, these are CD20 targeting cells, and you may have known or even gotten treated if you have a B-cell non-Hodgkin lymphoma. Usually when we start systemic treatment, we either start with rituximab alone if we are talking about a chronic indolent process, or we usually team up rituximab with chemoimmunotherapy backbone. So overall, rituximab and obinutuzumab certainly unanimously improved outcomes across lymphoma subtypes. The next step was to do something with this antibody. So could we then attach a linker, and that linker could have a chemotherapy attached to it, which is called a chemotoxin. And that's called an antibody drug conjugate. So the first one was what we call polatuzumab, which targeted an antigen called CD79B. In Hodgkin lymphoma, there's an antibody drug conjugate called brentuximab that sits on the Hodgkin cell that expresses CD30. But the net is that this antibody drug conjugate delivers chemo treatments only to the lymphoma cell and technically spares the normal cells. Polatuzumab is now considered one of the frontline standards of care for patients with high-risk, newly diagnosed diffuse large B-cell lymphoma in combination with chemotherapy. And then let's focus our discussion on the main topic of today, which is the CD20, CD3 bispecific T-cell engagers. So what are these? So this is actually the treatment. The bispecific antibody here, as you can see, this is an antibody with two prongs, which has been engineered to express it in such a way that the two prongs sit on two different cells. So one prong recognizes the CD20 antigen, which is expressed on your malignant B-cell lymphoma, and the other prong sits on the CD3 antigen that is expressed on your T cells. And that activates a patient's own T cell that causes the T cells to proliferate, basically expand at the tumor site, and then destroy the malignant B cell by a process called apoptosis, and releases these granules that are cytotoxic or basically dangerous to the lymphoma cell. So that is how a bispecific antibody induces the patient's own T cell, which has forgotten to actually destroy lymphoma, to program them in such a way that can now they attach to the lymphoma cell and cause it to die. So based on a number of clinical trials, we currently have in the United States 3 FDA-approved CD20, CD3 bispecific antibody treatments. We have what we call mosunetuzumab, glofitamab, and epcoritamab. As you can see, the technology of each of these 3 FDA-approved CD20 bispecific engagers is slightly different. Majority of them, so Mosun and EPCO, they bind to CD20 and CD3 in a 1:1 fashion. Glofitamab is designed in such a way that it binds in a 2:1 fashion. So as you can see, it has 2 CD20 prongs, and then this is the CD3, with the hope that it can have a little more potential for a little more potential for efficacy with regards to tumor kill. So we'll go into the FDA-approved CD20 bispecific antibodies to take you through how they have gotten approved, where do they fit in the treatment paradigm. So in diffuse large B-cell lymphoma, for patients who have had a relapse of their lymphoma despite having seen 2 lines of treatment, so this is in the 3rd line setting, we have 2 CD20 bites approved, namely glofitamab and epcoritamab. They are different because glofitamab is an IV infusion. However, it's only given for 12 cycles, so it's time limited. Epcoritamab, on the other hand, is a shot, so it's easier to administer because it's just a subcutaneous shot. However, it's given until progression, so it does not have a time-limited approach to it. And this is basically how we administer glofitamab. So usually what we do for patients who do get glofitamab is 7 days prior to glofitamab, we give them obinutuzumab. Obinutuzumab is a CD20 antibody. The idea is to clear out tumor from the blood so that when we give glofitamab, because even the first small dose is very effective, patients don't have a lot of adverse side effects such as cytokine release syndrome, which Dr. Crombie will go into detail. So as you can see, cycle 1 is a step up. Day 1, day 8, day 15. Of which day 8, we typically admit the patient for their first dose of glofitamab. Moving forward, everything could be done outpatient. Cycles 2 to 12 are administered every 21 days. This is the study that led to approval for glofitamab. It was a study of nearly 150 patients who were heavily pretreated with a diagnosis of aggressive large B-cell lymphoma. Patients had a median prior line of treatment of 3, with patients even up to 7 prior lines of treatment. It was also important to note that CAR T-cell therapy is approved for patients in diffuse large B-cell lymphoma, but there are patients who may still have a relapse despite going through CAR T. And interestingly, these trials included a third of their patients who had received prior CAR T and had relapse disease. And it's such a heavily pretreated subset, the complete response rate was 40%. I want to let you know that prior to the advent of these molecules, the complete response rate was in the range of 10% with anything that we had. And thus, it's really important to recognize that this frontier has really opened the floodgates and hopefully will continue to improve the outcomes for patients with lymphoma. More importantly, the time to response was short. Within 40 days, patients could start seeing symptomatic improvement of their treatment. Epcoritamab, as you know, was given subcute. It's administered indefinitely. This is how the step up is for cycle 1, where day 15 is when we recommend a patient has to get admitted inpatient so that a cytokine release syndrome that is likely to occur after day 15 can be managed when the patient is inpatient. And then moving forward, cycle 10 and beyond, eventually patients end up getting monthly treatments until they continue to respond. So with regards to epcoritamab, again, the baseline characteristics were very similar to patients who got glofitamab on the clinical study, 150 patients, heavily pretreated subset. You can see the median age of these patients. The range was 20 to 83. There was an 83-year-old on this clinical study who actually got this drug and were able to get this drug until indefinite treatment. Again, the time to response was about 40 days, and 1/3 of the patients had prior CAR T-cell therapy. Complete response rate, again, very good compared to what we had as a background to compare. 40% of patients had a complete remission with epcoritamab. And cross-trial comparisons are not favored in oncology, but I just want you to know that there is exceptional similarity between the two molecules. You can see 1/3 of patients had actually failed CAR T-cell therapy. There were patients who had progressed after an auto transplant, and whether they received CAR or not, their responses were similar. In terms of follow-up, as you know, glofitamab is a time-limited treatment. So after 12 cycles, patients stop if they are in a complete remission. And you can see that at a median follow-up of nearly 3 years now, more than 50% of patients still remain lymphoma-free. So that certainly is extremely encouraging. I, of course, would like to wait for the 5-year mark to make sure we can use the word cure, but I think we are getting there. So with all of these national conferences coming in 2024 and 2025, we're looking forward to updates of these clinical trials, both of which look absolutely promising. So I think the biggest question at this point in time for patients who have diffuse large B-cell lymphoma, who have been treated with 2 prior lines of treatment, if you look at the FDA label, at this point in time, they have the option to either consider CAR T-cell therapy, because that is approved in the 3rd-line setting, or they could consider glofitamab and epcoritamab in the 3rd-line setting. So the big question is, how do we choose? And I think the way I look at it is CAR T-cell therapy is a one-and-done infusion. We typically have seen patients who have brain involvement to have efficacy with CAR T-cell therapy. There is a longer follow-up with CAR T-cell therapy. However, with bispecific antibody treatment, there is this amazing allure because it's an off-the-shelf treatment. It can be available tomorrow. So for patients who have tumors that are proliferative, that are not able to wait it out, out for manufacturing. There is not an upfront commitment. Patients don't have to relocate to a CAR T site like patients who go through CAR T have to. So clearly, there is an appeal to an off-the-shelf antibody infusion like bispecific antibody therapy, also because there is a lower risk of cytokine release syndrome as well as neurogenic toxicity. So this is the proposed algorithm for patients with relapsed refractory large B-cell lymphoma. If you focus on the right, if they have had 2 or more lines of treatment, we look at it in the form of whether the patient is CAR eligible, whether the patient has a caregiver, is able to relocate, is open to an upfront infusion, or is the tumor characteristic such that they are able to wait it out for the manufacturing? And if they cannot, then I think bispecific antibody treatments are absolutely well served for this patient population. Moving forward, I'm going to switch gears and talk about the chronic indolent lymphoma, which is follicular lymphoma. We have made substantial progress, but we certainly need to do more because we need to keep patients in remission for a longer duration of time. So with that said, there were 2 pivotal studies exploring mosunetuzumab and epcoritamab. Mosunetuzumab is given as an IV infusion, and it is time limited. It is given either up to a minimum of 8 cycles or a maximum of 17 cycles. On the other hand, epcoritamab is a shot given indefinitely, and both of these are now FDA approved for patients with follicular lymphoma if they have had received 2 or more prior lines of treatment. This is the pivotal study that got mosunetuzumab its approval. Again, like all CD20 BiTEs, it also needs to be given in a step-up fashion. Mosunetuzumab potentially has the lowest risk of cytokine release and neurotoxicity. All of this could be done outpatient. Mosunetuzumab is being explored in clinical trials in a shot form. So we are looking forward to those updates as well. But in a 90-patient trial, you can see the complete response rate in a heavily pretreated population of a minimum of 2 lines of treatment to a maximum of 10 lines of treatment. The complete response rate was 60%. In terms of the follow-up, you can see that it does matter if the patients end up in a complete remission or a partial response. If they have a complete remission, you can see this green curve. That means their duration of remission lasts a very long time. So we continue to look forward to updates from this clinical trial as well. We are also beginning to now focus on why patients respond and why some do not respond to CD20 BiTEs. So I think so far we have looked at 3 potential mechanisms. Either the tumor gets smarter, meaning it just stops expressing CD20. So there is an antigen loss. So there is no way for the BiTE to actually attach to the tumor cell. Versus sometimes the T cells get exhausted. So the T cells have to kill the lymphoma cell. And sometimes based on the T cell intrinsic mechanisms, they might just get very, very exhausted. And then the third is the immune suppression milieu, meaning the environment that surrounds this interplay between the CD20 bispecific engager and the lymphoma cell. The milieu in itself may end up becoming quite immunosuppressive. So thus, the next generation of clinical trials is looking at either moving CD20 bispecific T-cell engagers ahead or up front, or combining it with molecules to actually overcome some of these potential mechanisms of resistance. In conclusion, I do believe that the field is rapidly evolving. We have just touched just the tip of this iceberg with this immune treatment. I do believe that it has potential implications in regards to exploring in other lymphomas such as chronic lymphocytic leukemia, CLL, mantle cell lymphoma. Some of the clinical trials that we have treated our patients on with relapsed refractory CLL, relapsed refractory mantle cell, I think have shown some amazing benefit. Looking forward to hopefully getting regulatory approval for these CD20 bispecific engagers in those subtypes as well. So with that, I'm going to turn back to Hope and happy to take your questions in the end.
Thank you so much, Dr. Kamdar, for starting us off with that overview. And as a reminder to the audience, please do continue to submit your questions through the Q&A box, and we'll get to as many as we can before we are out of time today. But it is now my honor to introduce our next speaker, Dr. Jennifer Crombie. Dr. Crombie is a hematologist oncologist at Dana-Farber Cancer Institute. She's also an assistant professor of medicine at Harvard Medical School. Thank you so much, Dr. Crombie, for speaking on our program today. And I will now turn the talk over to you.
Great, thank you so much. I will be picking up where Dr. Kamdar left off, talking a little bit more about bispecific antibodies in lymphoma. And so I'm going to be breaking this portion of the talk into two separate categories. First, I want to focus on some of the updates on clinical trials in bispecific antibodies. More that's happening here, and new combinations that are being explored, and new sequencing of treatment that's being explored. So I wanted to talk a little bit about those today, and then we'll switch gears and talk about the management of potential side effects that can occur, because as you heard, cytokine release syndrome is a unique side effect that can be seen with bispecific antibodies. And so there is some specialized planning that really needs to take place in order to safely administer this medication. And so I did see some questions coming in about toxicity, so hopefully we can address that here. So let's start with the clinical trials. So first, I want to just focus on diffuse large B-cell lymphoma and how bispecific antibodies are being used in this disease. We just heard about the treatment landscape and the algorithm for diffuse large B-cell lymphoma. I want to just highlight how much this is changing. So for a new diagnosis of diffuse large B-cell lymphoma, patients can still get R-CHOP, which we've been using for many years, or Pola-R-CHP, which was just approved in 2023. And then, as you heard, depending on how quickly the disease comes back, it may be appropriate for a patient to get CAR T-cell as their next treatment, or if they're not in good enough shape for that or don't have access, there are other options as well. And for patients who have the disease comes back after more than a year, we're still using the therapies that we've had previously, like additional chemotherapy. So the bispecific antibodies are currently approved in the third line. So glofitamab and epcoritamab, as you just heard, are the two for diffuse large B-cell lymphoma. And those were both FDA approved in 2023. So now the big question in the field is, should we be using bispecific antibodies earlier? Should we be saving them for the third choice, or is there an advantage to giving patients these efficacious drug as part of their initial treatment? So there are a few frontline trials looking at this. This is a figure from a recent review article that was published by a colleague of mine at Dana-Farber that summarized all the ongoing studies in the frontline. So that just means all patients who are getting their first treatment for diffuse large B-cell lymphoma. And as you can see, there's a lot happening within this field. Some of them are looking at targeted drugs, some are looking at CAR T, but these three in orange are ones that I wanted to make you aware of that are looking at adding in the CD20, CD3 bispecific antibodies to the first treatment. So one is looking at R-CHOP, which I mentioned is that first choice chemotherapy backbone, adding in epcoritamab. There's the SkyGlow trial, which is using that different backbone, Pola-R-CHP, which has recently been FDA approved with glofitamab. And then there's also the Olympia 3 study, which is looking at R-CHOP with odronextamab. So we're still waiting for the results of all of these trials, but these have the potential to change, again, the way that we treat the initial choice. This is a figure of an investigator study that we've been leading at Dana-Farber, again, looking at Pola-R-CHP, which is that chemotherapy backbone with glofitamab. And so we just wanted to know if we should add glofitamab right away, or should we wait after a few cycles of chemotherapy? And so this is another example of a study that's ongoing. What about for patients who have already had their first treatment? So there are a lot of different trials in this space, and you don't have to really know these in detail, but I just wanted to highlight how many trials are happening. And so there's a difference between a phase 2 trial, which is typically looking at the activity of a new combination. And so in this first column, you can see that bispecific antibodies are being combined with a whole host of standard options that we've been otherwise using. Some are chemotherapy, some are other CAR T cells, other novel drugs that we're using for diffuse large B-cell lymphoma. So these are smaller studies. They're just looking at how active these combinations are and making sure that they're tolerated together. And then there are a few phase 3 trials, and this usually implies that there's sort of a coin flip happening where patients might get randomized to either the standard treatment or the treatment that is including the bispecific antibody. And so there have been a few that are trying to compare which is really better. Should we stick to what we're already doing, or is there an advantage to adding in the bispecific antibodies? So these are a few. And one that I wanted to highlight is the StarGlow study, which is in the middle there, because this is one that's already read out. So I wanted to just quickly describe this study. So these were for patients who were not considered transplant candidates because of their age or other medical issues. And they, with a coin flip, either got a chemotherapy regimen called R-GemOx, which is one that we would use for patients who have had previously treated disease, or that same chemo backbone with glofitamab. And so there were almost 300 patients included in this study. And this just looks at the details. Most of these patients did not have prior CAR T, which is important to note, but the groups were similar in the group that got the standard chemo and then the group that got the chemotherapy with the bispecific antibodies. Just over half of patients had only had one prior treatment. So for many patients, this was their second choice, but there were a handful of patients who had more than one prior treatment. And you can see here that with the addition of the bispecific antibody, patients lived longer than they would have if they got just the chemotherapy. So this is a really exciting outcome to see for this regimen. It's not yet approved by the FDA, but we're waiting to see if this regimen will make it into our guidelines and allow us to use this for patients. We still don't know, should patients get CAR T cell there or this regimen. So there's going to be ongoing discussions about that, and it may be a logistical discussion with the patient as to what works better for them. But regardless, we're happy to see these data. So what about follicular lymphoma? So just to kind of review the treatment landscape. So for a patient who has a new diagnosis of follicular lymphoma, some patients might be able to just simply be observed if they don't have symptoms. But if they have a greater burden of disease, we generally would use chemotherapy regimens. Sometimes we'll use just an antibody, or sometimes an antibody with a targeted therapy. And then in the relapse setting, after people have had initial treatment, we have a variety of options. And that's where we have CAR T cell options, and then the 2 bispecific antibodies that you've heard about in the last talk. So now a question is, do we still need to use chemotherapy for patients with follicular lymphoma? Can we use these bispecific antibodies up front? So similar theme with diffuse large B-cell lymphoma. These were trials that we saw last year at our big annual meeting called the ASH meeting. We're about to have our this in just about 2 weeks, but they looked at mosunetuzumab, which is already approved in the 3rd line as a first choice, and they also used this as the shot instead of the IV. This was the detail of the study, but just to point out the overall response rate for these patients, it was a small study with 45 patients, but 96%. So almost all of the patients had a response, and 76% of patients had a complete response. When they showed these results, we didn't have the long-term follow-up that will be helpful to see how long the responses last, but these are quite impressive and may allow a patient to delay or not use chemotherapy. We saw a similar study with mosunetuzumab in combination with another drug called lenalidomide. This was the treatment schedule, but here the response was 91%, and just about 90% of patients had a complete response rate. So again, a small study and early, but very promising. We have 2 studies open at Dana-Farber looking at bispecifics in the frontline setting. We have a study of epcoritamab for follicular lymphoma, and then we also have a trial of glofitamab for follicular lymphoma, and this trial also includes marginal zone lymphoma, which is another version of a slow-growing lymphoma. So in the relapsed refractory setting, same theme, many phase 2 trials, and these aren't all of the trials. These are just some that I'm aware of and are available. But you can see combining bispecific with other agents that are active, and then a couple phase 3 trials, which is the coin flip comparing our standard treatment versus the standard treatment plus a bispecific antibody or a bispecific antibody alone. So we're really excited to see these. We didn't talk much about mantle cell lymphoma, but there is also activity of these drugs in this disease. Mantle cell lymphoma is that in-between lymphoma that you've heard about. Sometimes can behave aggressively, sometimes can be more slow growing. We generally use chemotherapy as the first choice, and this is also a topic for another day on how to treat this, because this is continuing to evolve. But right now, for patients who have disease that recurs, we'll often use pills. We have CAR T cell therapy, and but glofitamab has been studied in clinical trials in mantle cell lymphoma and has shown high rates of activity, but it's not yet FDA approved. So right now, the clinical trials that are ongoing are looking at glofitamab with other agents in the phase 2 setting. And then there's a phase 3 trial comparing glofitamab versus the choice of the treating doctor as the other option. So we'll have to wait to see what happens with bispecific with glofitamab in mantle cell lymphoma. So before I go on to the side effects, I just want to say those lists were examples. If you had a question about clinical trial options, it's always a good idea to talk to your doctor about this. Slot availability is always changing. The sites that have clinical trials open are variable, and so you can talk to your doctor to see what may be an option near where you live and if you're a good candidate. And it sounds like Lymphoma Research Foundation also has supports in place to help patients explore clinical trial options. So next, I want to switch gears and talk about managing potential side effects and the role of the care partner. So you heard already that there are some important side effects. While these are generally well tolerated and we can give these across a range of patients, it is important to know about some of these. And the most notable is cytokine release syndrome, or CRS. It's also important to be aware of the potential for neurologic toxicity, although this is very rare. Tumor flare, this is a phenomenon when there's a lot of immune response at the site of the lymphoma because these T cells are causing a lot of activity there, and there can be swelling. So the tumor can increase before it decreases, and that can be dangerous depending on the site of the lymphoma, if it was near the neck, for example. So that's something that we always want patients and providers to be aware of. Cytopenias is the word for low blood counts. And then with any treatment for lymphoma, we have to be thoughtful about the potential for infection. So cytokine release syndrome stands for acute systemic inflammatory, is an acute systemic inflammatory syndrome. And we often see high levels of cytokines, which are immune levels that can be secreted by your immune cells. Typically, cytokine release syndrome is characterized by fever, but can also have more severe presentations with low blood pressure, headaches, fast heart rate, or low oxygen levels. It's helpful to understand how we grade this. This is a grading system that was developed for CAR T cells so that we could be uniform across clinical trials, but now we can use this for the bispecific antibodies as well. So if you hear this mentioned, you can know what the doctors are referring to. So grade 1 is just a fever, but their blood pressure is stable, the oxygen level is stable. A grade 2 would be a fever with a low blood pressure or low oxygen level, but not requiring much support. And then grade 3 and grade 4 would be more severe, requiring medications to keep the blood pressure in a normal range or requiring higher amounts of oxygen. And so here's just a summary of what we saw in the clinical trials of the different agents in terms of cytokine release syndrome rates. So mosunetuzumab, 44%, with epcoritamab, it was about half of patients, and then a little above half with glofitamab. And while this does seem pretty high, if you look at the grading, it's very rare that patients would have a grade 3 or higher, which means that most of the time, if people have cytokine release syndrome, it's just a fever or potentially a lower blood pressure that didn't require a lot of medication to help keep it up. So maybe a patient was able to get IV fluids, for example, and have their blood pressure go back to normal. So, but it can be scary. And if you are one of those rare patients who have the more severe grade, we have to be ready to spring to action to help those patients, because we do have ways to support patients through that if it were to occur. It's also worth noting that the risk of CRS is different depending on the risk. It occurs at different times during the step-up dosing, depending on the drug. And so that can also be helpful to be aware that there may be a dose for your drug that's associated with the highest risk. You can know to expect that. The neurologic toxicity can occur. This can present with confusion or not being as awake as normal, not making sense, but this is very rare. We see this more commonly with CAR T cells. So if a patient gets CAR T cells, we generally tell them not to drive for 8 weeks. We also put patients on medications to prevent a seizure for 1 month. But for the bispecific antibodies, we don't have to have as strict of restrictions. If patients are feeling well and not having CRS or other side effects, it would not be unreasonable for them to drive. But it is important to know that this can occur, and that if it does, that your provider does need to know. Given the rarity, if neurologic changes happen, it's also important that everybody think about potential other causes for these symptoms as well. So these are some of the rates of the neurologic toxicity that can be seen with the bispecific antibodies. ICANS is the term for the neurologic toxicity that we typically see from T cell therapy, including CAR T cell, and it was all less than 10% with the step-up dosing that was used across the clinical trials. Some of the trials reported neurologic side effects, but these were more vague and included headache and other side effects, which may not be this same T cell mediated neurologic change. I also just wanted to highlight in this table that the side effect profile does seem to be slightly more favorable than the CAR T cell therapy, which has higher rates of neurologic toxicity, and with some of the products, higher rates of CRS as well. So what can we do to prepare for treatment? This is a picture that comes from a recent consensus recommendation that I was involved with a lot of other providers who were involved in bispecific clinical trials to help give guidance on how to prepare for treatment, and then if side effects do occur, how best to manage these. And so one of the key things is for doctors to make sure that they're evaluating the patient thoroughly, looking at whether the patient is really fit or really frail, and whether that would dictate some of the decisions, like should the patient receive the drug at home or in the clinic or in the hospital. And then also importantly, making sure that the patients and their caregivers have the education they need to know about these side effects, when to expect them, and how to reach out to the team if there are any concerns. So I mentioned this is what the staff responsibilities. It's also important for the provider to plan for CRS and make sure they've identified a hospital that has an ICU, which is just can allow for more support for the patient if they did have any of those oxygen or blood pressure changes, and also that the hospital that's nearby the patient has a drug called tocilizumab. This can be an antidote for cytokine release syndrome if it were to occur. It's also important for staff to make sure that their emergency room where the patient may go is aware of the side effects associated with these drugs and know to call the treating doctor if there are concerns. For the patient and the family, it's helpful to make sure that you understand the schedule, you know which product you're getting, when to expect the side effects, and then it is helpful to, if you call your doctor with a fever, if you know whether or not the blood pressure is stable. It's not mandatory that you have a blood pressure cuff at home, but it can be helpful. But you do need to have a thermometer in order to check if there is a fever, especially during that ramp up period. Once patients get beyond the ramp up period, the risk of all of these neurologic or CRS is very low. So it's really just in the beginning, the first few doses. We also recommend our patients carry a wallet card that has just some of these details. It has the numbers and it has some of the specific symptoms of concern. And that can also be handed over to an emergency room provider if a patient did have to go seek care. If patients have grade 1 CRS, which would be just the fever, we can treat this with Tylenol typically and encourage patients to stay well hydrated. We do have medications to suppress this. If it does occur, you can use steroids like dexamethasone. And then that antidote tocilizumab can be used if patients really just aren't improving despite more time going by and use of steroids. If it's more severe, these are patients who are going to need to definitely be seen. We need to make sure that their blood pressure is okay, their oxygen level is okay, and steroids can usually be helpful to settle down the immune system. And then the more severe 3 and 4, these are patients who are by definition going to be in the hospital. And this is where we're thinking about using our stronger medications to settle down the immune system. And then lastly, I just want to briefly just mention these other side effects. I talked about tumor flare. That can be treated with steroids. You just have to know about it. Low blood counts. We sometimes have to use the injections to help boost up the white blood cell count for patients. And then given the risk of infections, we always tell our patients to just be aware that they can be at increased risk of viruses. So to be careful, especially during the winter season, to be on medications to prevent shingles and certain pneumonia. And then the doctor that's treating the patient can monitor for low antibody levels, which can occur with a lot of different lymphoma therapies. So that was really all I wanted to get through, and hopefully we still have a few more minutes for questions. Thanks.
Thank you so much, Dr. Crombie. As you mentioned, we're going to jump into some questions now. Luckily, a lot of the questions had overlapping themes, so I think we'll be able to address everyone's concerns today. I did want to start out by saying that we received many questions about the potential effectiveness of bispecific antibodies for additional subtypes, and I'd encourage anyone interested in current clinical trials and treatments under investigation to utilize our clinical trials information service, which I linked in the chat here and which can also be found at lymphoma.org. But with that, we're going to jump into our first question here for Dr. Kumdar. How does the bispecific antibody spare non-malignant B cells, given that it utilizes the CD20 antigen, which is expressed on all B cells?
So usually, that's a great question. The answer is that no, it does not. However, that's why we are very wary of making sure that patients don't become hypogammaglobulinemic. So as Dr. Crombie alluded to, one of the toxicities or long-term side effects of CD20 bites is the potential to make a patient hypogammaglobulinemic, meaning you also target non-malignant B cells, and these are the B cells that differentiate into plasma cells to become antibodies. So it's very possible that for patients who are on chronic CD20 bites, their IgG level may go down to a point where they become more predisposed to infections. Typically, a threshold to give them IVIG, which is basically plasma from pool donors that has healthy IgG, is for an IgG level of 400 or under. But it's also important to note that patients who have low IgG levels, they basically can have a normal life, provided we can keep repleting their IVIGs. So as a result, it's very important, just like it is for CAR T cell therapy, as a function of the normal B cells getting affected, it is part of our treatment algorithms to check for monthly IgGs and replete them if they're typically under 400, or if patients have a multitude of infections happening. Sometimes our older patients, older than 80, we preemptively give them some IVIG during the winter months if they're on active bispecific T-cell engaging treatments.
Thank you. And Dr. Crombie, what would be an alternative treatment option if bispecifics do not work? This question is particularly for a patient with DLBCL who has relapsed after CAR T and is hoping to pursue a stem cell transplant. Excuse me.
Yeah, that's a good question. In that slide that I showed with the kind of current algorithm for management of diffuse large B-cell lymphoma, you may have seen that there actually are a few other agents that have recently been FDA approved. The treatment landscape of DLBCL has really been rapidly evolving over the past few years. Bispecific antibodies and CAR T seem to have the highest activity, but there are still some others that would be worth trying, like including loncastuximab, which is an antibody drug conjugate, is available. Tafasitamab and lenalidomide is a regimen that's available. Sometimes we use that in earlier lines of therapy for frailer patients, but it's still worth, that still could be worth trying. Often the best thing for patients to do in that setting when they've failed some of our best options is to look for a clinical trial, because that's where in these lists, maybe not one of the ones that I showed that has a bispecific, but we have many other options that are being developed for not only diffuse large B-cell lymphoma, but a lot of other lymphomas. We have CAR T cells that are binding different targets beyond just CD19. And there are even, there are other antibody drug conjugates being developed. So talk to your doctor, see if you're a candidate for a clinical trial, or ask the LRF, because sometimes the most, you might, get lucky with a novel therapy, but there still are a few other approved options for that patient to consider. But a transplant does sound like a good idea.
Thank you. And Dr. Komdar, if you're already on monthly IVIG, are you still eligible for bispecifics?
Yes, you're absolutely eligible for bispecifics.
And just another question for Dr. Crombie here. While being treated with a bispecific antibody, could patients experience similar symptoms to their cancer? For example, are bloating and abdominal GI issues during treatment with bispecifics a sign of relapse, or are they an indication of the bispecifics at work?
That's a good question. It can be tricky. Typically, we don't see a lot of GI side effects with the bispecific antibodies, although every patient is different and has different side effects from, the medications we may use to prepare for the treatment or to manage a side effect. And it also depends on where the lymphoma is. If you have lymphoma in your abdomen, it can be really tricky to know, is this the disease or a side effect? Whenever patients are on these therapies, we are watching patients closely. We're looking at labs that might be a sign that the drug is working or not, like a marker like LDH can be helpful. And we're also getting regular scans just to make sure that the drug is still working. And so sometimes we do need to get a imaging to make sure that the drug is effective and it's not a cancer-related symptom.
Thank you. And kind of on a related note, one more question for Dr. Kumdar, excuse me. As bispecifics work, could a patient show an initial response within 1 to 3 doses, but then experience a relapse within the 4th dose? Or is there no real response until a month or so in?
No, I think the initial response, based on all the clinical studies that were done prior to cycle 4 and cycle 3. And if you're in a complete remission, there's a very high likelihood that you will maintain the complete response. Typically, patients who have a partial response, we want to monitor them closely because they may likely not continue to respond. But usually, complete responders maintain the duration of remission. But have I seen complete responders relapse? Occasionally, but that's not usually seen quite often.
Thank you so much, Dr. Kumdar and Dr. Crombie, and I want to thank all of our attendees for joining today's webinar. And I know we had some questions left over, but I hope that we addressed the main topics for you. But remember, if you do have additional questions, you can always reach out to our helpline, and you can find that number and email at lymphoma.org, but I'll say it for you right now, it's 800-500-9976, or email is helpline@lymphoma.org. But thank you all again for joining us, and thank you so much, Dr. Kumdar and Dr. Crombie, for your time today. Hope you have a great rest of your day.
Thank you very much.
Thank you. Bye.
Take care.